Good afternoon. This is going to start the lecture on the reproductive system in your human diseases book, and this is chapter 11, and we're going to begin on page 222. We are, as always, going to start with anatomy and physiology rundown. I'm going to touch the topics of each condition and disease in this chapter. However, you need to make sure you read the book, the chapter in its entirety, so you will be well prepared for the exam. This chapter comes pretty easier to a lot of people because it is the reproductive system, and we hear a lot about reproductive system conditions and diseases in the media today. So we're going to begin on page 222, and I'm also going by your PowerPoint as well. And we're going to talk and begin with the female reproductive system, and then about halfway through we'll turn our attention to the male reproductive system. So the first part we're going to talk about is the external genitalia, which is the vagina on females. The external genitalia consists of the mons pubis, and it doesn't give you a picture in your textbook of the mons pubis, but that is that little fatty pad area that is that sits right at the top of your hips, basically. The labia is the lips of the vagina. Then you have the clitoris. The perineum is that little piece of skin that's in between the vagina and the rectum. We have the greater vestibular glands, the labia majora, which is your outer lips, and your labia minora, which are the inner part of the vagina. So that includes all of the external genitalia. Then we have the internal, and this is the things such as ovaries, and women have 2 ovaries unless they get them removed or get one removed. Then we have fallopian tubes, and these are the tubes that eggs travel on. And the end of the fallopian tubes are little finger-like projections, and if you look on figure 11.2, page 223, those are called fimbriae. And those finger-like projections basically make wave-like motions and attract the egg when it's released from the ovary, and it kind of grasps the egg and propels it through the fallopian tube. So that's the fimbriae. And then we have the uterus, and this is also called the womb. We have the cervix, which is the bottom part of the uterus, or the entrance into the uterus, and then we have the vagina, which is and we may also call this the vestibule area or the vaginal vault, because it's just the space inside the vagina before you get to the cervix. Alright, then we have to talk about breast. We have 2 breasts. And then within the breast, we have lobules, which are we have many lobes within the breast. And a lot of times when we do self-exams, when these little lobes get maybe impacted, and let's say you're breastfeeding, they may be impacted with milk, and sometimes they can be extremely painful, and you may think it could be, a cyst or some type of breast cancer nodule. And even in women that are not lactating, they can have like a hardened lobule, and they think that it's like a nodule that could be cancerous. But as always, you would rather be safe than sorry. We have the achini, the nipple, and the areola. So the areola is the space around the nipple. And we're going to be talking more about these as we go. So again, look at your figures in 11.1 and 11.2. There's many more parts, but I'm not going to make you know these. I may point out one thing here on 11.1 is the fundus. The fundus is important because it is the top of the uterus. And during pregnancy, this is where the placenta usually attaches at the top left of the uterus. And so after birth, when we're trying to get all of the placenta out, even though it's come unattached and has been removed from the body, we want to get any kind of placenta that may have not torn away from the uterus. And so we'll massage the fundus, which is the top of the uterus, to increase bleeding in the female. It is very painful, unfortunately, but it gets all of those contaminants out that could cause infection. So let's talk about going on to puberty. This is the second column on page 222. You know, girls hit puberty at different ages, and it seems like nowadays, they're hitting puberty a lot more early than they used to. This could be from hormones and food. You know, there's a lot of different myths on why puberty is happening early, and then some girls do not hit puberty until later. But we have rising levels of certain hormones, and you don't have to know all of the GN whatever, but we do have rising rates of hormones, and that sets off puberty. When this happens, it's going to stimulate the pituitary gland, and that's going to secrete, the pituitary gland will secrete a hormone called FSH, which is a follicle stimulating hormone, and LSH, which is I cannot remember what LSH stands for. It just left me. But FSH is, like I said, follicle stimulating hormone. So basically, this is going to help your eggs develop. You have follicles within your ovary, and the FSH will stimulate egg growth to deliver. Let's see. Oh, and then we have the follicles then can produce, if our hormones are working correctly, can produce estrogen and progesterone. Okay, progesterone helps you to actually have a menstrual cycle, and basically it helps build up the tissue within the uterus to support a pregnancy. Well, if there's no sperm to meet the egg just on those right 4 to 5 days in a month that a woman can be fertile, then the progesterone increases to create or the estrogen increases to create the shedding of the endometrium, which is the inner part of the uterus. So progesterone increases the endometrium, and the estrogen actually helps release the endometrium, which makes you menstruate. And menstruation, some terms that we need to talk about with that. We have a term called menarche. This is only used the very first time a female starts her menstrual cycle, and that's called like the age of menarche or menarche. This can tell an endocrinologist and infertility physician a lot about a female's reproductive health. If they start later, they could be saying it's hormonal issue, ovarian related. If it starts a lot earlier, maybe they're secreting too many hormones. So the age of menarche is very important for a physician to know. And again, menarche is the very first time they started their menstrual cycle. Usually a complete cycle lasts 28 days. Now that's not bleeding, that's 28-day cycle and then a menstrual cycle. So you have 28 days basically where within your cycle, that's if you've ever taken birth control pills, you'll always notice that you have 28 pills, and then a few of them are just sugar pills. So you have 28 days, and this is your hormones doing their different things, building up the endometrium, and then it sheds, and then the cycle starts over again. So again, there's a 28-day cycle. Then we have, like I said, the ovarian part, it happens first, and that's called the ovarian cycle, and then the menstrual cycle. So the ovaries really produce a lot of the hormones that make us have a menstrual cycle. So if they're not working, or if something is deficient or malfunctioning in the ovaries, then our menstrual cycles may not happen. They could happen less commonly. They could be extremely heavy, extremely light, frequent, or infrequent. There's a lot of different things that can happen. There's some other terms I want to give you. Let's look on page 224. Let's look at the corpus luteum. This is an empty follicle that after an egg is developed, it converts into a hormone and helps the patient build up that endometrium to support a pregnancy. And like I said before, if the body does not become pregnant, then the estrogen increases and other hormones as well, and then we shed the endometrium, which is your menstrual cycle. So that's the corpus luteum. These are not in your book, I don't think, but I wanted to give you some terms. I'm not really going to test you on them, but you may hear some of these, especially in the coding world. You may see some of these diagnoses like dysmenorrhea, and that's DYS, and then menorrhea, and that means painful menstruation. You may say menorrhagia. You may see menorrhagia. That's basically the act of bleeding, or a bloody discharge, basically, or excessive bleeding. Let's see, anorrhea, that basically means the absence of menstruation. So those are just some of the terms that you may see in the coding world that have to do with menstrual cycles. Alright, going on to diagnostic tests and procedures. So some of the different things that we can do and that you may have to code for that deal with the reproductive system vary. We have the pelvic examination. In females, used to it was every year, and I believe there's new guidelines now that's every other year, but most women that I know still go every year, and most insurances do pay for it every year. If you have had like an abnormal pelvic exam or abnormal pap smear, you should really have to go twice a year for at least 2 or 3 times until you have a negative result. Then we have the bimanual rectal exam. This is where a couple of fingers are inserted into the vagina facing up, pointing up. Then we have one into the rectum, and then we have one, the other hand is on top, and they're all pushing up to make sure muscle mass is good, and the ovaries and uterus and cervix are in the right place, and they're not enlarged or too small or anything like that. Then part of the pelvic exam is the pap test, and the whole word for this is the Papa-Nicolau smear, but we just call it a pap smear for short. And now we have the thin prep that a lot of physicians are using in place of the pap smear. But this is going to test cervical swab from inside the cervix. We need to get inside the cervix and from the outside of the cervix. And a lot of people that have had a hysterectomy or partial hysterectomy, every once in a while a physician may still want to test the vaginal vault because they can still have some cervical cells within the vaginal vault even though they've had a hysterectomy. Another test is a D&C, dilation and curettage. This is where the cervix is dilated, and the curette is basically a little thing that looks like a spoon, and the physician can go in and remove substances that way. So if there's a miscarriage and we have to dilate the cervix and remove the contents of the uterus, that way the patient has to have a D&C. Ultrasound, we can do laparoscopy where we go through the belly button or the navel, as well as several other little small incisions around the navel. And then we can have a hysteroscopy as well. And a hystero means hystero means uterus. So if we're doing a hysteroscopy, that means we're going into the uterus, maybe to see what's going on inside the uterus and to check it out, see how much endometrium we have built up. We may have too much endometrium that's growing on different places other than the inside of the uterus, and when we have this is called endometriosis. You have a picture of a physician doing laparoscopy. Let's see. So with that said, we're going to go on into diseases of the female reproductive system. And we're going to first talk about some cancers and things that may cause cancers. The first one is a sexually transmitted disease. However, if it's not treated, it can lead to infertility and it can lead to cancer. And it's called pelvic inflammatory disease, which is also known as PID. This usually happens for multiple sexual partners, especially when sex is unprotected. And what happens is different sperm collect around the cervix, and those different sperm have different DNA, and it causes different lesions within the cervix and can cause cervical cancer. Then cervical cancer, this basically leads to what we call HPV, the human papillomavirus. And a lot of women have human papillomavirus. It's something within the last 7 or 8 years that we've discovered that about 1 out of every 2 women have HPV. And it doesn't mean that's a bad thing. You know, it's a sexually transmitted disease, yes, but it can be, you know, it's just one of those things that some people may have, so it's not really anything to be ashamed of. And, you know, there's some viruses that may have, that may produce warts. Give me 1 second, guys. Okay, sorry about that. Alright, where were we? Anyway, we were talking about human papillomaviruses. Some virus strands can cause genital warts, and but most of them do not cause genital warts. They can just cause infertility, and some can cause cancer, and some may not. Just because you have HPV does not mean you have genital warts, and just because you have HPV does not mean that you're going to have cervical cancer. It's more likely that you will, but it doesn't necessarily mean that you will have cervical cancer. So there's a lot of misinformed Americans, I believe, out there about HPV, but yes, it is considered an STD. However, 50%, probably, I would say like 75% of the women in America and men probably have HPV and don't realize it. Then we have endometrial cancer, and the endometrium, as I said before, is the inner lining of the uterus. So sometimes when this lining is not shed a lot, we can get an endometrial cancer. Sometimes it'll start as endometrial hyperplasia, basically, and they'll go in and they'll take a little sample, it's like a vacuum cleaner. They'll go in and suck a sample of your tissue out of the uterus to test it. And then if it has hyperplasia, then usually they'll want to do something further, or do more of a biopsy, or start treatment. And usually the treatment they do is a hysterectomy. Then we have fibroid tumors of the uterus. I won't say most, but a lot of these are benign. They can be scary when you get that call saying you need to come or we found a fibroid tumor, but most of them are benign, and these are called leiomyomas. They're the most common form of tumors in the female reproductive system, and mostly benign. Then we have ovarian cancer. Ovarian cancer is extremely deadly, because a lot of times it's not caught until the end. It's considered one of the many types of cancer that's a silent killer. May not give us any type of warning until it's too late, but and that's why your PowerPoint says that it's a little difficult to find early because of that. There's not really any screening tests for this, unfortunately. Really, the only thing we have to do is, if you are at risk for ovarian cancer, you just have to keep a check on it. And there's a blood test called the BRCA test. It's extremely expensive, and insurance will really only pay for it if you have like so many people in your family that may have a certain type of breast or colon or female reproductive cancer. Ovarian and breast cancer both share that BRCA test. That's what we call it. It's like the BRCA1 and BRCA2, but we call it the BRCA. So if you, some risk for ovarian cancer is what we call nulliparity, and it's basically no pregnancies. You've never been pregnant. That can put you also at risk for osteoporosis. If you have polycystic ovary syndrome, metabolic syndrome, if you're overweight, short and petite in stature, if you smoke, and the list can go on and on and on. So a lot of people find out that they're very at risk for ovarian cancer. And if you are, I would suggest just to stay on top of it and keep screening. And then breast cancer, a lot of times we feel masses and they're benign, but then a lot of times they're not. So you have to do those once a month screenings on yourself, usually a week after your menstrual cycle. That way you can, and it's best to start in the shower, because when your skin is wet, the oils are usually secreted still from the day from maybe your lotion or deodorant, and your hands glide over your breast a lot more smoothly. And you may have to educate a patient on doing this. Even though you're coding, you never know when you may be pulled to the help in some other place. Then we have mammograms. I think it talks about that. Yeah, on page 228, it shows you an example of a woman having a mammogram, and they changed the guidelines for this. It seems like every year. Like, what age do you start, or how many times should you have it? Once a year, once every 5 years, once every other year. So you just have to trust your doctor that they will stay up with the changes. And it's always best, again, to be safe than sorry. So some of the other signs of breast cancer that you can look out for is discharge from the nipples, irregular borders of little lesions on your breast, like an enlarged area in the breast, or a sunken in pit, or pitting is what we call it, an orangey texture look to the breast, any kind of breakdown like underneath the breast or even on top of the breast too. All of those are some of the things that you want to look for with breast cancer when you're screening. Fibroadenomas is one of those type of benign cysts in the breast, and those are the kind that if you have to have a cyst, you want to have this fibroid adenoma because it is benign. They can swell up and make you think that you do have breast cancer, but just remember, most breast cancer does not appear immediately. It grows over time. So, for instance, I know a patient personally that all of a sudden, her left breast got completely swollen up, and it was just painful. She couldn't hardly touch it. She was afraid she had breast cancer, and I told her, I'm not saying that you don't, but I'm saying that breast cancer usually grows slower and doesn't pop up overnight. It turns out that she just had a little breast infection because she had shingles as well. So that's something to keep in mind as well. Then we have breast cysts, and cysts are something as well that are benign, but sometimes they may require treatment to have them removed so they don't grow into something else. And then we have fibrocystic changes. This can happen in all women, especially if you eat chocolate and drink caffeine right before your menstrual cycle while you're ovulating, or a little bit after you ovulate. You may start feeling your breast getting really tight and tender and very full, and this is usually with fibrocystic changes. But these are very rigid feeling when you do your breast exam, and something that you need to go to the doctor for is going to be separated. Okay, so it's not going to make your entire breast tissue feel rigid. That fibrocystic breasts do that, but an actual something that you should be concerned about is if there's something separated from other conditions, and you only feel that around soft tissue. That would be something you would need to check out. Menstrual disorders. Let's talk about that. Menstrual disorders on page 231. Oh, they do have the terms in here. Good. Amenorrhea is, like I said, the absence of menstrual cycle, and this can be due to a million things. A lot of times it's, of course, it could be menopause or a sign of premenopause, or it could be polycystic ovary disease. So this can happen, and basically, the cause of it can be a lot of different things. It could be hormone related, it could be stress related. I mean, it can be linked to pretty much any condition. Let's see. Let's go on to dysmenorrhea. Dysmenorrhea is painful menstruation, more painful than, bad cramps. This is painful that puts you out of commission for 5 to 7 days, however long your menstrual cycle is. So this is painful or difficult menses. So this usually begins about 6 months to a year after menarche, so when menstruation begins. So risk factors for people that have this are being under 20 years old, early onset of puberty. If they start puberty a little earlier, they're more common to have very painful menstruation. If you have irregular menstrual bleeding, that can cause dysmenorrhea. Smoking can also cause dysmenorrhea. So that is dysmenorrhea. Now let's go on to menorrhagia and metrorrhagia. These are commonly confused. But menorrhagia, let me see. I'm sorry, menorrhagia, on page 232, is excessive or prolonged bleeding. And this is basically the same etiology. It can be caused from an early onset of period, smoking. There's all different things that can cause it. And then metrorrhagia is bleeding between menstrual cycles, so spotting usually. So that's menorrhagia and metrorrhagia. Premenstrual syndrome, PMS. A lot of people think that's actually the act of bleeding when you're on your period, but PMS is actually the week or so before your period. Usually when you have mood swings, your breasts are tender, you just are fatigued, you may be running a little low-grade fever. So that is actually considered premenstrual syndrome because it's pre-menstruation. Okay, and there's not really anything that is going to be, the golden pill or golden fix for this. It's just something you may have to take Advil for pain and to reduce inflammation. There's different things for everyone. Then we have PMDD, so premenstrual distress disorder, I think is what, dysphoric disorder, my bad. This is a severe type of PMS, okay? So this can happen. It causes like very bad mood swings. It causes horribly tender breasts, and you can read all about it on page 232 and 233. So to manage your premenstrual syndrome, you should avoid salt, avoid caffeine and alcohol, exercise regularly, eat a healthy diet, make sure you get enough sleep, take calcium and vitamin vitamin B6, and if you don't take it, eat foods rich in it. Manage your stress, take pain relievers, and take oral contraceptives. And a lot of times physicians will give birth control pills in order to help the pain level of menses go or be lessened or go away for women. Okay, let's talk about endometriosis on page 233. Okay, endometriosis I've mentioned a few times already, and this is just an increase of the endometrium tissue that's built up within the lining of the uterus. You can have it extremely built up, and it can also be on top of the uterus and even on top of your intestines and other organs that it shouldn't be, and even in the rectum and the vaginal vault as well. So when this happens, this is called endometriosis, and usually the doctors will not give you anything. Sometimes they may give you birth control pills, and then if it gets severe, they may do like a DNC or even a hysterectomy. But risk factors for endometriosis are your age, your family history, never giving birth, and menstrual history being either if your menstrual history is very short, if it's very heavy, or if it's very long, it lasts longer than 7 days basically. The most common symptom, of course, is going to be pelvic pain, and then really bad symptoms during menstrual cycle like heavy cramps, just extreme fatigue, extreme tenderness, lower back pain. It can also, if it's in your rectum and on your colon, it can cause diarrhea, even constipation, sometimes bloating. There's all different types of things that can happen there. So that's, a lot of people don't think that endometrial tissue can get on your colon and other organs, but it actually can and cause those symptoms. Sometimes they can be misdiagnosed as irritable bowel syndrome or maybe celiac disease, but in fact, you just have endometriosis on your colon. So the etiology of endometriosis is idiopathic, so we don't really know what causes it. It can be caused from several different things. Alright, let's go on to disorders of pregnancy. And unfortunately, a lot of people don't like to talk about these because they are a source of a sensitive topic. But we're going to talk about spontaneous abortion or spontaneous miscarriages and ectopic. And we're going to begin with ectopic pregnancy. Ectopic pregnancy, instead of when the sperm meets the egg, it's supposed to travel into the uterus and implant. And in ectopic pregnancy, the sperm meets the egg, it travels, but implants within the fallopian tube. And that can be extremely dangerous for the mother and the fetus. So it's very difficult to diagnose, okay, because the patient may still have a positive pregnancy test, and we think everything is fine because we usually don't go to the physician for the very first time until the patient is about 6 weeks along. It can also cause a negative pregnancy test and you don't know what's going on, and then all of a sudden you have horrible pain right beside your ovaries on either side. So if you ever have one side of pain that's just severe and it's just getting worse and worse and worse, it's very possible you could have ectopic pregnancy. There's not really any way to save the fetus. Unfortunately, it has to be aborted, or it will kill you and them. So going on with that, we're going to talk about spontaneous abortion or miscarriage. This can happen a lot of times. The sperm meets the egg, it travels, implants into the uterus, but then that progesterone just didn't maybe secrete enough to give us a thick endometrium, because we want a very thick, healthy, and rich endometrium in order for our fertilized ovum to implant. And if we don't have that, it may implant, but it miscarriages, and it'll slough off, and then it comes unattached from the wall and we have a miscarriage. And it's very common, and it seems like it's more common now than it was. 50% of all pregnancies, and the number may actually be higher now. So a lot of times it could be a genetic abnormality of the fetus, okay? So everything is good up to, almost 3 months, and then all of a sudden something happens while we're reproducing inside, and all of our DNA is being made and split. Something happens with genetics, and you spontaneously miscarry. So any of those can happen. Preeclampsia. This is another disorder of pregnancy, and this is basically high blood pressure during pregnancy. It can also cause increased protein in the urine. And women that are pregnant are going to have a little increased protein in the urine. However, if it's too high, that could be indicative of high blood pressure. And again, high blood pressure in pregnancy that is pretty high is considered preeclampsia. And it can be mild to severe. And it can be treated usually with medications, but we have to make sure they're safe for pregnancy. So some of the symptoms of this, of preeclampsia, is you're going to have headaches, pretty bad headaches, sensitivity light, you may have dizziness, nausea, vomiting. So you can see there during pregnancy, these are very similar to pregnancy symptoms as well. So you just have to monitor your blood pressure during pregnancy. And a lot of times it may not develop until the last trimester, when the baby is developing and getting larger by the day. The second and third trimester, they get larger by the day, and it puts so much stress on our bodies that it increases the blood pressure. The next thing on page 235 is gestational diabetes. This happens in 2 to 10% of pregnancies and can happen more. A patient may not be diabetic at all of a sudden they get pregnant, they get diabetes. It could be the other way around too. The patient has diabetes, once they get pregnant, no diabetes, and they never have it again. So it's something that happens like that, and nobody's really completely sure why it happens. But basically, we may have higher insulin levels, and so it's lowering the blood sugar, or your insulin may not be developing enough. And so this is going to put the fetus at risk for early miscarriage, and we don't want that to happen. So, going on to female age-related diseases. We have menopause. Of course, this is like the cessation of a menstrual cycle. around a certain age, and there's not really one specific age for menopause. It's a broad range. It can happen very young in life, or it can happen very late in life. We also have uterine prolapse. This happens when the uterus falls into the vagina, or it can fall into the rectum. And some women come in and they're very scared because they see something, coming out at them, and they think, what's going on? And it's the actual uterus coming out. Because the uterus has two strong ligaments that support it on this side. So as we get older, everything kind of, dies down, is not as strong, and so these ligaments kind of get loose, and then it causes the prolapse of the uterus. Then we have a cystocele and a rectocele. A cystocele is when the bladder is moving down, again not supported by ligaments, and then we have the rectocele is the bulging of the front wall of the rectum into the vagina. This can happen as well. A woman that has a lot of vaginal births is more common to have that rectocele because of the stretching out of the rectum and the vagina during vaginal birth. Alright, now we're going to move on to the male reproductive system and talk about the anatomy of the male reproductive system. We have the penis, the scrotum or the testicles, we have the seminiferous tubules, we have the seminal vesicles, the prostate gland, and the bulbourethral glands. I can never say that word. Those are some of your different parts there. On page 11.6 you can see all of these. That's a very good picture to look at. So we're going to talk about diagnostic tests and procedures to do with the male reproductive system. We have, of course, the physical exam where the doctor will just take a look at the genitals. Then we have the testicular exam, and men should really do this once every month or once every couple of months. They should squeeze the testicles and feel the sac that's surrounding it to make sure there's not any lumps, because testicular cancer is not a joke. Digital rectal exam. At an office, the physician will do a digital rectal exam to make sure the prostate is where it's supposed to be and it's not too small or really enlarged. So that's what they're doing. They're checking prostate. We have the PSA, the prostate specific antigen. This is a blood test that's done on men beginning at a certain age, and that can help detect cancer, or what we call BPH, which we'll talk about in a second. But like I said, it's a blood test that we usually do once to twice a year on men. Then we have urodynamic testing. This is things that have to do with urinalysis. We may catheterize the patient and see how much they're voiding in the catheterization, and then how much they may have left after we catheterize in the bladder. A cystoscopy, where they can go in and look inside the bladder. Alrighty, let's look at, go on and start talking about diseases of the male reproductive system. And the first one we're going to talk about is prostatitis. Okay, this is inflammation of the prostate gland, and it's usually due to infection of some type. So we can have what we call acute bacterial prostatitis, and then we can have chronic bacterial prostatitis. And then we can just have chronic prostatitis that's not caused from a bacterial infection. And then we can have asymptomatic inflammatory prostatitis. So we have a lot of different things that can happen with prostate, and these are just some. So asymptomatic, of course, means having no symptoms, and usually with symptoms the male may complain of painful urination, not urinating enough, not being able to climax, different things of that nature. Oops. Then we have, let's go on to page 239. We have the epididymitis, and this is the inflammation of the epididymis. This can happen usually from different sexual partners, or a history of a sexually transmitted infection or disease. It can happen from urinary tract infections, prostate infections, uncircumcised penis, mainly because of bacterial growth when it's uncircumcised. Catheterization, surgery around that area. There's a lot of different reasons why this can happen. But when we have this causes a lot of testicular pain. It can swell and be extremely painful for the patient. They may have painful ejaculation during intercourse. They could have a fever. They could even have a lumpy area in the testicles, and then enlarged lymph nodes in the glands. Okay, back to the next disease we're going to talk about is orchitis, and this is inflammation of the testicles or the testes. The prevalence of this is not really known. We don't really know what causes it. It tells you in your book that risk factors includes like not being immunized for the measles, mumps, and rubella, especially the measles and mumps that can cause orchitis. You can get it from having multiple urinary tract infections, multiple sexual partners, and basically the same as the epididymitis as well. For this, you mainly have to take anti-inflammatories, ice, which can be painful, but those are some of the things that we have to do to treat it, and sometimes we may need antibiotics. The next thing is cryptorchidism. Cryptorchidism is basically hidden testicles, and this happens a lot of times in infants, but it can happen in older men as well. But the testes do not descend from the abdomen, okay? And so it may just be one, or it could be both of them. But as I said, newborns are usually the main ones that have this. They don't descend. And, at first when they're born, they will ascend and descend, voluntarily a lot. But when it's this condition, they don't descend whatsoever. Testicular cancer. This, of course, it can be a very deadly cancer, and it can be in one or both testicles. That's why it's very important for men to do testicular self-exams. Signs and symptoms usually are the lumps. You may feel it, or you may see like a reddened or scaly area on the testicles. Sometimes it can be painful to urinate or painful during sexual intercourse. So those are your main side effect or signs and symptoms that something may be going on that could be potentially cancerous. We're going to go on to male age-related diseases on page 240, and the first one that I mentioned a while ago is benign prostatic hyperplasia, and this is also called BPH, and this happens with the prostate. It happens as we get older, and basically the prostate enlarges, but it's completely benign, and we have to take medication for it. Then, of course, we have prostate cancer. This can happen as well when we get older, especially with BPH. If you have a history of BPH, then you're more at risk to have prostate cancer. And then we have erectile dysfunction as well. Erectile dysfunction basically speaks for itself. It's the inability or trouble becoming erect, or it could be the inability to climax as well. Let's see, and then we're going to go on to sexually transmitted diseases. I'm going to kind of go over this pretty fast because the book is pretty good about this. Your first one that's not curable right now is HIV and AIDS. And remember, HIV comes first, and then after a certain period of time, it may develop into AIDS. Now, if you do have a lot of money to invest in those autoantibodies, you can use all those medicines, but they're extremely expensive and they have horrible side effects. And they're basically antiretrovirals. It can prolong the HIV from turning into AIDS. And then once it turns into AIDS, we usually see the patient not live much longer after that. Gonorrhea is very common around here. This is the fancy name for it is Neisseria gonorrhea. It causes burning during urination. Sometimes you can have a greenish or yellowish discharge for men and women. Then we have syphilis. Syphilis is usually a painless sore, and it looks like an ulcer or a canker sore. Sometimes you may have a rash because they're all together, and the fancy name, or the correct name for this one, is Treponema pallidum. So that is syphilis, and you have some pictures of different things there. Chlamydia, this kind of goes hand in hand with gonorrhea. It's very common. It's usually asymptomatic, so it usually has no symptoms. A lot of times we may not find it until we've got HPV, and then we realize it's possible that we may have had an STD without knowing about it. The official name for this is Chlamydia trachomatis. Excuse me. Then we have trichomoniasis. We also call this trichomonas or trick. This again is extremely common, and the proper name for this is Trichomonas vaginalis. You're going to see this too, having the yellow or frothy like discharge. It has a certain odor, and if you ever have worked in the medical field around this, you'll notice and realize that trichomoniasis has a certain odor to it. We have genital herpes. We have type 1 and type 2. Type 1 is usually oral. Okay, so this is like your cold sores and fever blisters. And then we have herpes type 2, and this includes your genital herpes. And these are fluid-filled blisters in the genital area. And they can happen other places too, but it is on contact. So even if you were to use a condom with somebody that was herpes type 2 positive, they could spread it from pelvis to pelvis as well. And then we have genital warts, and these are usually not painful, and they're little benign growths that happen, and we usually have to have them frozen off. Let's see, you have some pictures there that shows you all the different types of STDs. So we are going to end with that. So like I said, I just barely traced a little bit of this chapter and talked to you a little bit about each disease, but I want you to read the book in its read the chapter in its entirety to make sure that you're well prepared for the test.